That's us. Next slide. All right. So this is, I think, the last, as we mentioned in previous sessions, this is very Williams front-loaded in terms of the lecture series. Then eventually you'll get less of me, blessedly. So I appreciate your patience. I hope that I've not driven away half the group initially. But this morning's talk is specifically on methadone treatment. We'll talk a little bit about the pharmacology, meaning how it works, and then also the stages of recovery. So what the process is as someone goes through methadone treatment. Methadone's a really interesting medication, both from how it actually works and then also some of the regulations and the way it is sort of treated differently than any other medication. We'll touch on this later in the talk, but there is no other medication that has federal rules just written specifically about it. And the historical antecedents around those rules are sort of based around historical racism and other really sort of complicated features that are beyond the scope of this talk. But in any case, let's talk about methadone. So next slide, please. Our goals for this talk, or objectives, we'll review the neurobiology and societal impacts of opioid use disorder. As I mentioned in previous talks, I am required by law to have a really complicated picture with the brain and a bunch of arrows pointing in different directions. So I'll have one of those and I'll pretend like I understand what it means. We'll talk about the pharmacology of methadone for opioid use disorder. So why methadone in particular? What's effective about it? What are the challenges with it specifically? We'll talk about the evidence behind it. And what success looks like with treatment for opioid use disorder in general, but also with methadone. So we're not just talking about abstinence from other opioids, we're talking about things like remaining in treatment and not dying and not contracting HIV or hepatitis C. So there's lots of ways to measure success, and methadone does all of those things well, and we'll talk about that. And then we'll talk about the different stages in recovery with methadone treatment. So there are different phases with how you initiate and maintain methadone treatment, and we'll talk about what those phases look like and what the potential hazards and downsides are of each of those. And we can do the next slide, please. Just a brief review from prior talks. So addiction, defined by SAMHSA, which is for the large body that thinks critically about addiction and has a lot of guidelines around the treatment of it. Addiction is the strong desire to use and the inability to control use. So remember, the hallmark of addiction is the loss of control. And then continued use despite obligations, social functioning, impaired health, and also spending a lot of time obtaining and using opioids. So the hallmarks of addiction are this loss of control and use despite adverse consequences. And that is different than dependence, which is a purely physiological state. You can become dependent on blood pressure medications. You can become dependent on antidepressants. And that is not addiction because people are not seeking out Zoloft and using it despite harmful consequences typically. And then this is a technicality, but the DSM-5, which is sort of the handbook or the guideline by which we make specific diagnoses, basically categorizes substance use disorder as this broad category that encompasses both misuse and dependence. So not probably super germane to a lot of you, but just to say that part out loud. Next slide, please. As promised, here's one slide with a lot of arrows and a brain that I will pretend to understand now, but it's all kidding aside. If you're on TikTok, you've heard at least one person talk about dopamine at some point, and it is an important neurotransmitter that is actually responsible for feelings of reward and happiness. And there's an entire circuit in your brain that is responsible for sort of maintaining joy and happiness and what they call hedonic tone, which is a great term. And this is the limbic system, and this is comprised of the ventral tegmental area, the nucleus accumbens, and it functions something like a circuit. And you have these neurons in the ventral tegmental area that release dopamine into the nucleus accumbens. And then there are other areas of, things that incorporate emotional experience into the stimulus itself. So in addition to just the feeling of joy and happiness, what are the circumstances around that? And then how do you remember those things? And how does your brain interpret all that information and integrate it? So it's a really complicated process. It's not straightforward, but with addiction and use disorder, there is an almost literal rewiring of the brain. And the prefrontal cortex is the part of the brain that is really responsible for integrating all this information from the lower levels of the brain. So it's the area that's responsible for morality and higher functioning and critical decisions and those kinds of things. And the prefrontal cortex can become impaired with addiction, with use disorder, and that's part of the process. So as we've learned from TikTok, most addictive substances will increase the level of dopamine well beyond what you normally get from rewarding situations. I was just talking to some colleagues yesterday. I run, and we were talking about the runner's high, which is ostensibly from dopamine. I have never experienced it. I have found running hateful in the 10 years that I've been doing it, but I hear that some people get increased dopamine from running. But the point I'm making here is that the substances that are used or misused will give you far more dopamine than a 14-mile run will, which is not surprising to me. And what happens is that over time, as your brain is being bombarded with dopamine, it has to adjust. And so it actually reduces the number of receptors just as a way to kind of mitigate this sort of overflow of dopamine. And as a result, it takes more of whatever you're using to actually maintain that joy and that the level of response that you're getting before. And then also the joy you get is not the same as it was previously. You have fewer receptors, so you have less capacity to experience the pleasurable sensations that come along with that. When you go into detox or when you go through withdrawal, those physiologic processes are relatively quick, but to be able to kind of get back to the point where your receptors start to kind of regenerate and you get more of them and you're able to kind of achieve joy and happiness again, that actually takes some time. So even after the immediate phase where you're off of whatever the substance of concern is, it takes a good long time before you can get back to a state where you start to enjoy life in the way that you did before you started using whatever it was. So it's a very complicated process, and the medications we use are aimed at kind of targeting certain places within this. So I appreciate you indulging me for that slide. Next slide, please. And not to relitigate this, I know that you're all here because you all know these things, but I still think it's important to say a lot of this stuff out loud. The United States is kind of unique in that midlife mortality has been going up, and midlife mortality in the 40s, 50s, 60s. Like this is an area where most people should be maintaining health. All the accidents and diseases of childhood are past. They're in a relatively stable place, and so this is where death by accidents, death by murder, death by poisonings. This is where people die from those things. And then as you get older, then heart disease and cancer sort of once again take over as sort of things that cause mortality. And in most countries, and really all countries, midlife mortality in non-Hispanic whites has been sort of steadily decreasing over time. But in the United States, we are different. Unfortunately, our midlife mortality has been increasing over time, and that's largely driven by illnesses related to and consequences of substance use. So poisonings is another way of saying overdose. Lung cancer, so nicotine is a substance use disorder. So lung cancer has actually kind of come down. People are smoking less. That's good. But there has been an increase in suicides, chronic liver disease from alcohol use. And just as a kind of comparator, diabetes has remained relatively stable. So it's this increase in mortality of people dying in middle age is driven almost exclusively by substance use, by mental health issues. And this corresponds with people just saying they're not doing as well. They're saying their mental health is not as good as it used to be. And there are also increases in chronic pain. We saw a similar pattern in during the AIDS epidemic in the early 80s. Again, something that affected people in the middle of their life and not at the beginning or at the end of it. Next slide, please. And people are dying in 2019, and the data kind of COVID disrupted a lot of things and made the data sort of hard to interpret. But in 2019, right before the advent of COVID, about 1.6 million people over the age of 12 said that they had opioid use disorder within the past year or met criteria for it. In 2020, 93,000 opioid-related deaths, which was a 30% increase over 2019. And that's as we were sort of transitioning into COVID. 1% of primary care patients have a documented opioid use disorder, and documented is doing a lot of heavy lifting in that phrase because almost certainly it is under-recognized and underdiagnosed. But only 20% of the patients with the documented opioid use disorder have received treatment. So it's under-recognized and also significantly undertreated. And people who have a new diagnosed opioid use disorder have visited a primary care physician in the past year. So it's not necessarily that these folks are not engaged with healthcare. It's that healthcare doesn't do a good job of identifying and treating folks with opioid use disorder specifically. Interestingly, 80% of doctors feel very comfortable saying that they can identify opioid use disorder, but only about 35% feel that they're comfortable treating it. And that disconnect has persisted. There have been a lot of changes. We've talked about buprenorphine in past talks, or Suboxone, which can be prescribed by any primary care physician with a DEA license, but there is still a lot of discomfort and stigma and sort of mystery around that medication. This graph on the right shows the differing waves of opioid-related deaths. So wave one was the OxyContin, and that wave two was the heroin overdoses that happened after OxyContin. Wave three are the synthetic medications, or substances, I should say, like fentanyl. And we are currently actually in a fourth wave of stimulants that are adulterated with things like fentanyl. So overdoses kind of come in these waves, and we're right in the middle of a fourth wave that's actually related to stimulant use, but stimulants that have other substances in them and people don't know about them. So when I was practicing in Philadelphia, I would get calls from the Department of Health just encouraging me to give my patients who use cocaine, Narcan, because there's been so many overdoses associated with it. So that's the state of affairs where we are right now. Next slide, please. And again, just the data in a different sort of view. We're seeing overdoses go up related to any opioid use, and that's the figure on the left-hand side, and it's going up for both females and males. And then the figure on the right-hand side is prescription opioid use. So right before, like in the mid-2010s, I believe it was the CDC came out saying that doctors should stop prescribing medications that their patients are overdosing from. And then there was this knee-jerk reduction in opioid prescribing that I think was also catastrophic in a different kind of way. But in any case, the overdose deaths became fewer prescription drugs and more unprescribed medications. Next slide, please. And the slide after this, please. As I alluded to earlier, so overdose is obviously important. You know, as a doctor, like my goal is to keep people from dying. I think not to oversimplify things, but there are lots of other potential hazards and harms that come along with substance use and opioid use disorder specifically. And when we think about injection drug use specifically related to opioid use, there's all kinds of complications. So I think HIV has a lot of press and is probably the one that springs to mind when you think about complications from injection substance use. But I can tell you that it is the #1 spread of hepatitis C, which, by the way, is extraordinarily treatable these days, but probably also undertreated among folks with opioid use disorder. You can certainly get things like botulism and wound infections and skin and soft tissue infections from use. But other things that you might not think is bad commonly is you can get heart valve infections that are absolutely catastrophic. You see these all the time on the inpatient setting, what's called endocarditis. And these patients can have the potential to do very poorly. When we talk about risk factors, this is because you might be using an environment that is not clean or safe. You might not have access to clean water. Sometimes folks are using lemon juice to actually dissolve whatever product they're injecting, and that can cause its own sort of local site reactions. People will often lick needles, though that actually seems to be relatively regional, but people will lick needles in order to kind of facilitate entry, and then even sometimes to taste the substance just to make sure that what they're injecting is what they think that they're injecting. And as a result, you're then injecting whatever bacteria happen to be in your mouth. And I'm sorry to tell you, but people's mouths are very dirty. So that can cause local skin infections. It can cause heart valve infections. And then needle sharing is also a potential to sort of spread disease among folks who are injecting drugs as well. So there's lots of ways to introduce health hazards from injection use specifically. Next slide, please. I think I've used this slide in previous talks, but this is basically the progression from sort of how substance use progresses, basically. So one will use initially, and they'll go from a quote unquote normal state into a euphoric state and then come back down and then use again. And you'll note that the euphoric peak is a little bit less, and then a little bit less, then a little bit less. And then eventually the use becomes to prevent withdrawal and to prevent these feelings of discomfort because you are now in physiologic dependence. So you're using to feel normal and not to experience euphoria, and you're using to avoid the sensation and the physical distress that comes along with withdrawal. The idea of medication-assisted therapy is to, and next slide, please. I think that'll give you that's the stuff, is to get you back into this normal range in a smooth and sort of well-regulated way so that you're staying normal and not bouncing back and forth between withdrawal and feeling kind of okay. Next slide. We talked about the different medications for opioid use disorder previously. As a reminder, methadone is what they call a full agonist. And if you look on the left-hand side of that picture that's on the left, methadone is sitting squarely in that opioid receptor. It operates the receptor the exact same way something like oxycodone or fentanyl or heroin does. So it does all the things that opioids do. And that includes pain relief, that includes euphoria, that includes constipation, and that includes respiratory depression, which is the thing that kills people with overdoses. Contrast that with buprenorphine, which is, as you'll recall, a partial agonist. So buprenorphine sits kind of in the receptor, but is not fully stimulated. And as a result, buprenorphine does all the things that opioids do, but it has a ceiling effect. So it takes a lot of work, and it's almost impossible to overdose on buprenorphine. It can be done, and certainly usually that's in combination with other substances. But because it's not a full agonist, it's only a partial agonist, meaning it only partially stimulates the receptor. It's much, much harder, which is why we like it. And then naltrexone, the third medication used for opioid use disorder, it blocks the receptor. And so that does not do any of the things that opioids do. In fact, it keeps them from doing those things. And so it does not cause respiratory depression, but does not make you feel good, doesn't really do anything other than keep you from using. And it does reduce cravings in as far as we know. If you look at the graph on the right-hand side, and because I'm a science dork, I like graphs, but the orange line is how methadone works. So because it's a full agonist, the higher you push the dose, the more likely you are to push someone closer to death. There's better ways to say that. But it's a very deliberate process when we're increasing dose because you can achieve the point where you actually suppress someone's respiratory drive and they can overdose with it. Buprenorphine, that is hard to achieve, and naltrexone, that's not even a consideration. Next slide, please. So I mentioned this early on in terms of what does success look like? So I think before I started doing this with any kind of regularity, even when I was a physician, my view of any kind of substance use disorder, whether I was talking about nicotine, alcohol, opioid, what have you, my view was that someone was not successfully treated unless that they were no longer using the substance. My mindset was that abstinence was success and everything else was a treatment failure. And I'm now, happily, my view is much more nuanced than that. There's lots of ways to measure success, and abstinence doesn't have to be one of them necessarily. Certainly, if that's the patient's goal, wonderful, and that's a great thing to achieve. But if you keep folks from dying or from overdosing, that is a success, and this medication does that. If you're able to keep someone coming back to treatment and engaged in care and talking to counselors and remaining part of the system, that is a success. If you can reduce recidivism, meaning if you can keep someone out of jail and keep someone from having untoward contacts with the legal system, that is a success. And even if the use continues, that's still a win. And just like we talked about with the injection use, if you can reduce the spread of HIV or hepatitis C or other infectious diseases, that is also a success as well. Next slide, please. So we'll go through one by one. On the right-hand side, by the way, this is someone taking their methadone. This is what it looks like. They get their medication dispensed in the cup. It's a very rigorous process that we'll talk about in a couple of slides. But let's talk about death first, which is a weird sentence to say out loud. What these graphs are, these are what are called survival curves. So the closer you are to the top of the graph, that represents the percentage of people still alive or still with a positive outcome that you're looking at. And as that line dips lower, that's people either experiencing death or whatever the adverse outcome is. So looking at people treated with methadone, which are the solid lines, you see that after 20 years of treatment, about 75% are still alive, as opposed to people who are untreated controls who are not on methadone. That number, those people sort of drop off the grid much lower and achieve the same rate of death in about 10 years. So methadone saves lives is the point of this chart. Next slide, please. In terms of staying in treatment, very striking, similar to the graph that you would see with Suboxone. So folks that receive methadone over admission, so this is like looking 2 years, this particular graph, you can tell because it looks like a mimeograph. This is probably an older study, but folks receiving methadone, about 80% of them stayed in treatment after at least 2 years, and then people who do not receive medications for opioid use were lucky if they were retained in treatment for about a year. And this is a study of 100 patients that were randomized to either methadone or to a detox or placebo. This is probably not something that could be done today because it would be viewed as unethical because we know that methadone works so well. So that's one of the ways that you know this is an older study. Next slide, please. In terms of recidivism, we're keeping folks out of prison. So this is a little bit of a different look on the graph on the right-hand side. But if you randomize someone to either treatment with methadone or just detox, the people who were treated were much less likely to be committed for crimes after their release. So they were much less likely to return to prison compared to folks who just went through a detox. And this is, again, an older study from the New England Journal of Medicine from 1969. So methadone keeps people out of prison. Next slide. And reducing disease transmission, this is, again, it feels so weird for me to say I'm getting old. That a 2005 study is an older study, but that's where we're at. But this is a study in the Journal of Medicine that did what's called a meta-analysis. They looked at 28 different studies and compiled all the information and put it together. And at the end of the day, without getting too deep into the weeds, it significantly reduced the risk. Methadone reduced the risk of high-risk behaviors of HIV transmission. So people on methadone were less likely to engage in injection drug use or high-risk sex, and were less likely to actually seroconvert, meaning develop HIV disease. So let's talk a little bit in the few minutes that we have left in the flash talk about what the different stages in recovery are. So the first stage is induction therapy. So what it'll look like is someone will come into what's called an opioid treatment program. As I think I've mentioned before, this is not something that can be done in a primary care office. This has to be done in a special clinic that is beholden to special regulations, that has the methadone on site, is dispensed. They have very regulated processes. There are always sort of government agencies coming through and making sure you're doing everything okay. But the patients will come into this office and they will begin what's called induction. And they are started on a comparatively low dose of methadone, and there is a very protocolized way in which that dose is increased. And it doesn't matter if the person is in withdrawal or still using, because methadone does not, because of the way that it works, it's not going to send someone into withdrawal, but someone may be in withdrawal when they come in to see us. It's important to know that this initiation period, as we're trying to find the right dose for these patients, is probably the highest risk period, because these are people who are trying to come off of whatever substances they're using and are starting on a medication that may not yet be at a therapeutic dose. And so they feel awful. So they may be at a stage where they've lost their tolerance. They're being treated with a medication that may not actually get them to where they need to be, or the process may not be moving quickly enough. And that's a dangerous cocktail where someone may actually go out, use, and then overdose a little bit more easily. So this is a very tenuous time period in the initiation phase. But with each dose they take, they build up methadone in their system. Methadone is a very slow building medication. It takes time to build up in the tissues and the bones, and it also takes time to come out of the body. And that's what we like about it, because once we get someone into a steady state, the peaks and valleys are much smoother, as opposed to sort of the spikes that you see with fentanyl use, where the levels go high, the levels go low. With methadone, once you hit the right dose, the levels stay very level, and people are able to feel normal for a long period of time. But it takes a little bit of time to find out what the right dose is. Every time someone comes in, they're assessed before treatment. They will often have a blood alcohol test. We'll make sure that they do not come in looking terribly intoxicated. And then they'll be assessed after treatment to make sure, again, that they're leaving in okay shape and that they're doing all right. Next slide, please. Our goal is to get them stable as quickly as possible, but in a way that is safe, because as I mentioned, if you increase the dose of methadone too quickly, you do run the risk of the respiratory depression and overdose. So you're trying to find a dose that keeps folks functional, but does not intoxicate them, does not have them experiencing withdrawal, does not sedate them, and just has them without excessive cravings. And typically, the way this goes is you get 3 or 4 days with the same dose without missing a dose. And if you feel like you're still not where you need to be, then the dose will be increased. And we're monitoring other parameters in addition to how they're feeling and how they're looking, things like their EKG. There are certain changes that happen with methadone if you're not cautious. So you have to make sure that you're not causing dangerous arrhythmias while you're treating as well. If someone misses frequently, they then may lose the tissue stores of the methadone. And as a result, you may have to start all over again. So if someone is missing, does not come to the clinic for 3 or 4 days, they may lose their tolerance, and you have to start from scratch. So you can't just start them on the same dose, because again, you run the risk of overdose and causing problems. Next slide, please. After someone's been stabilized, they're in the late stabilization phase, and these patients may remain on the same dose for years. And really, that's the goal. If you find the sweet spot and they're doing great, then they can be maintained. They can come in on a daily basis, maintain the same dose, and then everyone feels good about that. But you do need to adjust the dose from time to time, and that's not uncommon. And that can happen because of changes in medications, life circumstances, health changes. And if someone suddenly needs an increase in dose, that should prompt your evaluation for what's going on. Why has their dose changed all of a sudden? Have they had a return to use? Are they experiencing withdrawal? Or has something else medically happened with someone that suddenly their dose has changed? Next slide, please. And then with sustained recovery, these folks are going to the clinic on a daily basis. Eventually, over time, they may get take-home doses. So if someone is coming here on a daily basis, they're getting all of their doses. They are participating in counseling. They are abstinent from other substances. Their urine drug toxicology is as expected. Over time, they may be able to get doses that they can take home with them. So initially, people are coming in here 6 days a week for their dose. Over time, they may only have to come in 5 days a week, and then eventually 4 days a week. And then eventually people are taking home 30 days worth of medications, which is a long process. But you can get to a point when you're in sustained recovery where you don't have to come into the clinic every day. But I will say that early on, you're here 6 days a week. So that can be really burdensome if you have a job or sort of life circumstances, or the commute is not easy. It can be a lot of work to actually maintain recovery in a methadone treatment program. When you're in sustained recovery, you continue to see counselors. Then you also come and see the physicians at least a couple times a year, just to remain engaged in treatment. Next slide, please. So that is what treatment with methadone and opioid treatment programs looks like and why we do it. So methadone outpatient treatment has excellent evidence for recovery, but also evidence for things like reduced death, reduced overdoses, reduced retention in treatment, and reduction in spread of disease. People successfully on methadone look like, quote, everyone else. So our goal is to get someone with a feeling of normalcy. So these folks will not look like they are intoxicated. They should also not be in withdrawal. The goal is to get them feeling normal. And this can take a couple of months to achieve. And there are always sort of fits and starts and bumps in the road, and you have to make adjustments along the way. How long someone stays on the medication is determined. Some folks, their goal is eventually to come off of whatever medication they're taking for opioid use disorder. Other times they're on these medications chronically. Sometimes they desire to switch to other medications. So it's not unusual for someone to want to switch from methadone to, say, buprenorphine therapy just because it mitigates the burden of having to come to the clinic quite so much. But in any case, this is an individual case-by-case basis. And again, I would make the same plea that I always make, is it's really important to not stigmatize this medication. This is not substitution. This is a life-saving treatment that keeps people from dying, keeps people from getting sick. So I see 2 questions in the